Hi there, I'm Andrea Habenicht, a final year student in the Bachelor of Science in Psychology at the University of Limerick. I'm here today in this video to talk to you about a less widely recognised mental health disorder, panic disorder. Many of us have left a horror film saying, "I almost had a panic attack," or "I thought my heart would beat out of my chest, it was that scary." But this is just one way we fail to understand the severity of panic disorder and what these patients actually experience. Now, people often assume that panic attacks are the disorder, but they are simply one symptom. And while people use the terms panic attacks and anxiety attacks interchangeably, this isn't actually the case. The attacks differ primarily on duration, as anxiety attacks are built up over time, whereas panic attacks have a very sudden onset and peak within 10 minutes. Panic attacks are defined as discrete periods of intense fear or discomfort accompanied by at least 4 of the following symptoms: palpitations, sweating, chest pain, dizziness, depersonalization, fear of dying, and a fear of losing one's mind. They are also often accompanied by a sense of imminent danger or a need to escape, and can be expected or unexpected. Now, while many people have experienced panic attacks at some stage, all of the following criteria are needed for a panic disorder diagnosis: recurrent unexpected panic attacks, at least 1 month worry about having another, worrying about implications of panic attacks, and behavioural changes brought about by said panic attacks. Panic disorder has a worldwide prevalence of between 2 and 5%. It affects twice as many females as males, and over 1/3 of those diagnosed with panic disorder also have agoraphobia, or the fear of crowded or public places. Currently, there are cognitive behaviour therapies, pharmacological treatments, or combinations of both to manage panic disorder, but no definitive cause is known. However, one widely regarded cognitive approach to panic disorder is David Clarke's model of catastrophic misinterpretations. Clarke suggests that panic disorder is maintained by the following cycle of anxieties: catastrophic misinterpretations of bodily sensations, such as thinking chest pain is a heart attack, which leads to catastrophic cognitions, such as belief in imminent death or public humiliation, which leads back to focusing on the physical symptoms and causing further anxiety. Now, here's where current research has attempted to build on Clarke's model. This study examined 3 types of cognitions: social, physical, and mental, and whether type of cognition had an effect on both cognitive and biological treatment condition outcomes. 143 panic disorder patients were given baseline measures of the Panic Disorder Severity Scale and the Thoughts Rating Form. Following this, they were assigned to either a cognitive behaviour therapy condition, which consisted of cognitive restructuring and breathing retraining, or an imipramine drug treatment condition for 12 weeks. Results indicated that physical and mental catastrophic cognitions had no significance in terms of predicting either treatment condition's outcome, but participants from both groups who reported more intense social cognitions than physical or mental tended to report more substantial panic symptoms after the study and at the 6-month follow-up. This suggests that social catastrophic cognitions have more of an impact on our panic levels than physical and mental, and therefore social cognitions are the most closely tied to success in overcoming panic disorder. This could be due to lingering feelings of social embarrassment preventing patients from engaging in previously avoided situations, or it may be that social catastrophes are simply subjective. A doctor can assure you you aren't having a heart attack, and a psychiatrist can assure you you aren't crazy. Social embarrassment, however, is completely subjective. So what does this mean for real-world applications? Well, it suggests that further concentration on social cognitions over physical or mental may be important in aiding a future panic disorder treatment. Also, the participants from the drug condition had their fears of social catastrophe closely linked to overall poor treatment outcome. Firstly, this suggests that a cognitive behaviour therapy or combination approach may work better, and secondly suggests panic disorder patients should be further encouraged to re-enter social situations they avoided prior to treatment. However, all participants in the study had mild to moderate agoraphobia. As mentioned earlier, over 1/3 of all diagnosed with panic disorder have agoraphobia. So this questions whether social catastrophes are only a better predictor of treatment outcomes in patients with this condition, or even just mild to moderate agoraphobia. This might not be true for severe cases. On a biological note, selective serotonin reuptake inhibitors are considered the best medication for panic disorder, but weren't used in this study, so maybe type of antidepressant used could also affect the predictive values of the cognition types. Overall, although you and I may experience a panic attack at some stage, we must remember panic disorder is much more than just a panic attack. And we must hope that future research, perhaps in terms of the social cognition outlined above, will add to Clarke's model and help to reduce overall panic severity. Thanks for listening.
created using Powtoon.